Everybody, and welcome to this week's eEcho meeting, specifically on the topic of patient blood management. And it's really great to see all of you here. Gastro Echo is hosted by the Gastro Foundation in association with Project Echo at the University of New Mexico in the States. And sessions are held every week on a Wednesday. And there are different series of topics, and one of the types of sessions we have, not every week, but every now and again, is on patient blood management. The chat box will be open for questions and comments, and I'd really like to encourage you to make this as interactive a time as possible. This is an opportunity to ask the difficult questions. We're very fortunate to have a very experienced person in the room, and I want to really encourage you to use the opportunity. So with that, I'd like to introduce an old colleague, Professor Marius Coetzee. We worked together for 12 years at the University of the Free State until 2015. Marius was head of the Department of Hematology at the University of the Free State, and has many interests, but he's an expert amongst many things in bleeding disorders, laboratory hematology, but also iron deficiency, and has developed a special interest in patient blood management over the last few years, and has become one of our South African PBM champions. Now, Marius's background is in hematopathology, so he is very well situated to talk to us about the laboratory aspects of iron deficiency diagnosis, which can often be very challenging, especially in the context of inflammation, cancer, heart failure, renal failure, that sort of thing. And there's also a lot of controversy around what the cutoffs should be for certain laboratory tests that we use. So with that, Marius, I'm really looking forward to your talk. I'm sure all the other people in the room are as well. And thank you for agreeing to talk to us about this very important topic. And I'm handing over to you. You're welcome to share your screen. And again, welcome to everybody else who's just joined us in the last few minutes. Marius, you're muted.
Oh, there. Thank you for this opportunity. Iron is supposed to be such a sort of everyday metal, but every time I start reading about it, I almost have to start learning afresh. So what I'm going to do is actually just discuss the laboratory diagnosis of iron deficiency, which is somewhat in flux at the moment. Okay, so my base specialty is pathology, and I also just want to say there sometimes are trends or tend to be fashions in diagnostics, just like in therapeutics. And in the end, we just have to do what is best for the patient. Okay, so I'm just going to quickly go talk about the prevalence of anemia, the essence of iron physiology, look at the current diagnostic criteria, other existing assays, and then we're just going to look at the diagnosis of iron deficiency in more complex situations. And please give me as much feedback as you can. Okay, so this is a global prevalence in 2019 based on the WHO website, saying that women of reproductive age are there, about 30%. There's 30% prevalence of anemia in children under 5, almost 40, and in Africa specifically, almost 60% of children under 5. And it's said that about 50% of anemia is caused by iron deficiency. Okay, these are data from South Africa, but if you have better data, please let us know. So this Shisona 2014, it's a nutritional survey. Almost 1 in 5 adults in South Africa are anemic, and 10% of children under 5. In a survey in Cape Town, in Turawa, showed that about 22 to 44% of women of reproductive age are anemic. And then the two publications about anemia in pregnancy, but I think it's Tunki, 43.7% of pregnant women, and then a systematic review by the same group, 31% of pregnant women being anemic. So let's just talk about the definition. So iron deficiency is a health-related condition in which iron availability is insufficient to meet the body's needs, and which can be present with or without anemia. This is a sort of a consensus statement with the chief author being Capellini. So let's just quickly look at the physiology. Here, the total column is 100% of body iron, 60 to 70% being in hemoglobin, 20 to 30% being stored iron, ferritin and hepsidin, a bit in muscles, iron-containing enzymes, and then transferrin is almost nothing. So the main point is there's very little iron in the plasma usually. I'm not going to go into bone marrow hepsidin as a technique of diagnosing iron deficiency. Okay. So actually, only about 3 milligrams of iron is coursing through our circulation. And there's a turnover of about 20 to 25 milligrams on the left-hand side of the picture from the bone marrow, erythrocytes, macrophages recirculated. And then on the right, the main points are that if we have increased erythroid demand or hypoxia, we reduce the hepsidin secretion, iron and inflammation then increases it, and with increased secretion, we have the iron is retained in macrophages or not absorbed from the gut. Okay. Here we're looking at the things that influence hepsidin secretion. So as we know, hepsidin locks iron in the macrophages or prevents its absorption. So if you have increased erythropoiesis, for instance, with erythroferrone, we reduce the secretion, while if we have increased circulating iron, increased iron stores or inflammation, all those three then stimulate hepsidin secretion. Okay. So we said there's about 3 milligrams of iron in the circulation, and this is what it consists of. So firstly, we're just talking about free or labile iron in the plasma, and those are actually minute amounts, 1 to 10 micromolar. It's difficult to measure, and its use is basically for iron overload states or poisoning. Iron bound to transferrin, which is also pretty labile, and then iron bound to circulating ferritin, very little. And apart from the fact that the total concentration of ferritin in the blood sort of reflects the iron stores, the extent to which the ferritin molecules are filled with iron can also be studied. Okay, so let's just look about screening for anemia. From what I have read, the latest values, sort of current values for the interior of South Africa, adult males is about 13.5 to 17.5, and females 11 to 16. At the coast, the Cochrane 2021 from the UCT study, males 13.6 to 17, females almost in the same range, and the NHLS values are plus minus the same. In Bloemfontein, we're at about 1,500 meters, and our HPs are supposed to be about 0.2 to 0.5 grams per deciliter higher, according to the WHO guidelines. There's an interesting thing. A study in Switzerland showed that there's a very small rise in ferritin as people live at higher altitudes. But it hasn't been confirmed by other studies. We'll watch this space. So then it gets to preoperative anemia screening. And I think there's little doubt that 13 grams per deciliter is the minimum for both females and males. And this is, of course, because if a male or female has the same operation, they lose the same amount of blood. But if a female starts from a lower starting point, the effects are more severe. So there we have this 13 grams per deciliter for adults, supported by Schunder in a recent recommendation from the Annals of Surgery. Wise et al. I think Vernon was a co-author. The anesthesiology recommendation, also that from London, the Center for Perioperative Care, and the World Health Organization's call for implementing patient blood management of 2021 supports this. Okay. Firstly, we all have learned that iron deficiency is associated with microcytosis, but actually this morphological finding, pencil cells and all that, is not very specific. The indices like the mean cell volume, MCHC, mean cell hemoglobin, and so forth are actually not very specific. And then to complicate this, iron deficiency is common and can be superimposed on all sorts of other anemias, including hemoglobinopathies. So what should we do if a patient presents with a lower hemoglobin? The Society for the Advancement of Patient Blood Management, with their 2019 guidelines, suggested that one check the renal function, do reticulocyte count, the iron binding capacity, ferritin, check for vitamin B12 and folate, check the thyroid function, and they even go further. The Center for Perioperative Care suggests a serum transferrin saturation, C-reactive protein, which influences the ferritin, etc., renal function, folate and B12, and then reticulocyte hemoglobin, if available. So we know that iron deficiency comes with a lot of symptoms from fatigue, exercise intolerance, hair loss, restless legs, etc. So we should have a high index of suspicion. And then just to emphasize that one gets iron deficiency without anemia. And this is actually based on an idea from Karen van den Berg of Sanbes. Here you have a bottle from which you're drinking. So you and perhaps have some friends. If the bottle is full and the glass is full, but as you continue drinking, the level in the bottle drops, but your glass can still be full until the bottle is almost empty, and then your glass is empty. Okay, so let's look at the everyday tests we do for the diagnosis of iron deficiency. It's usually the serum iron, transferrin, and then the transferrin saturation, and then ferritin. But the interesting thing is that what we think is serum iron is actually the iron bound to transferrin. Our routine tests are not sensitive enough to pick up the free iron. And the only use of measuring serum iron is for calculating the transferrin saturation. But there's a circadian rhythm, it's highly variable, and of course, if the patient has recently received iron, just an iron tablet or syrup, it can temporarily be increased. Now, I mentioned total iron binding capacity in ferritin as being equivalent. Basically, the total iron binding capacity is done in the States. There you add excess iron to the test tube, and the excess removed, and you see how much iron has been absorbed by the plasma. In the rest of the world, we basically just determine the concentration of transferrin by some immuno method. And from that, we can actually just mathematically work out the total iron binding capacity. So just remember that actually these are pretty much the same thing. Okay, then transferrin saturation. You have to determine the transferrin then, and because two atoms of iron are bound to one transferrin molecule, usually one can actually calculate the percentage of transferrin which carries iron. The interesting thing is that transferrin is a negative acute phase reactant, so its concentration drops during inflammation, completely the opposite of ferritin. Ferritin is usually done by an ELISA method, but apparently even though we've been using it for decades, the test is not that standardized. And of course, it rises by about 25% during inflammation. Okay, so as I mentioned, there are various things can interfere with results. Recent oral iron or IV iron can push up the values, and then tumor necrosis factor inhibitors can push down the serum ferritin. Okay, I just mentioned that you can actually also determine the non-transferrin bound iron, that's the free or labile iron, very small amounts, but it's difficult to measure. And its only use is actually for iron overload or with iron poisoning. And then if you look very closely at ferritin with measuring magnetism, you can use the capacity of ferritin to carry up to 5,000 atoms of iron. So when you are iron deficient, the ferritin molecules on an average will have a little bit of iron in them. If you move towards an overload, there's a lot of iron per ferritin molecule. But this is a demanding technique. Okay, then just quickly, just to recap that if there is inflammation, you get hepsidin secretion. Iron is actually then kept back in the spleen and the bone marrow to some extent into the macrophages, and it's not absorbed. Okay, so the thing is, how do we then diagnose iron deficiency in the presence of inflammation? Because during inflammation, you get various cytokines like interleukin-6 and other mediators, which also stimulate the secretion of hepsidin. And as we mentioned, it reduces the absorption. So, and in the presence of inflammation, a ferritin under about 100 micrograms per liter is probably indicative of iron deficiency. And it's just interestingly that transferrin tends to drop during inflammation. Okay, and this is just to say that if we have a table where if we have iron deficiency without anemia, the hemoglobin can still be normal, but the ferritin and the transferrin saturation will be decreased, and you'll have increased transferrin receptors. With iron deficiency anemia, the hemoglobin drops. But if you have anemia of chronic disease or anemia of inflammation, the ferritin can go up, but the soluble transferrin will not actually be affected. With iron deficiency and chronic disease, you might even have a lowered ferritin. But in the last two, the giveaways actually the CRP that's raised. Okay, this I'm not going to go into the details of this table, except let's just look at the top row. And there you can see we have iron deficiency without anemia, iron deficiency with mild anemia, and an iron deficiency with severe anemia, where the stores are completely empty. So here we can see that these are the current sort of values for serum ferritin that are being used, serum iron, and the transferrin you can see kind of goes up. The saturation drops. You can look at the reticulocyte hemoglobin content, and that's the amount of hemoglobin per new reticulocyte entering the circulation, and that drops. Bone marrow iron, of course, is absent when before you start developing anemia, and then you can even look at erythrocyte zinc protoporphyrin. Okay, so when we assess inflammation, it's probably best to start with your clinical acumen. The CRP is pretty useful. There is some mention of this molecule alpha-1 acid glycoprotein, but I can't get much about it. And then you can even use the ESR, but of course that's only mainly used for monitoring autoimmune conditions. Okay. I also just want to mention functional iron deficiency or iron-restricted erythropoiesis. Here's when the situation when there's hardly enough iron available for erythropoiesis. And it occurs mainly in two settings: anemia of inflammation or chronic disease, where the iron is withheld in macrophages. And then on the other hand, where erythropoiesis stimulating agents have been administered, and there's actually not enough iron for the erythropoiesis that's actually begging for iron. Somehow the iron stores can often not be mobilized quickly enough. Here the percentage hypochromic cells or reticulocyte hemoglobin can be useful. Okay. There are 6 guidelines that have been published in the last 10 years. Thomas and et al. Looking at functional iron deficiency. Pavord et al. The UK guidelines for iron deficiency in pregnancy. The World Health Organization's guideline on the use of ferritin concentrations. SNOOK, the British Gastro Society, 2021. Coe et al., the American Gastro Association, one, and then Fletcher, that wrote from the British Society of Hematology, that talked about the lab diagnosis. So I'll just quickly look at these things. Right, Fletcher. So this is about the lab diagnosis, but not in pregnancy. Okay, it emphasizes the first bullet point that normal red cell indices do not exclude iron deficiency. And then you can use the percentage hypochromic cells. But it's not available all over the place. The nomenclature also differs with the red cell, the hematology analyzer that you're using. Okay. The mean reticulocyte hemoglobin content is useful in renal failure. So if the content of hemoglobin per new reticulocyte decreases, it's suggestive of iron deficiency. And then if there's a complicated case, a close examination of the peripheral blood morphology might help to resolve the issue. Okay. But here we get to the contentious values of ferritin. And Fletcher then says that there are good, there's good evidence for below 15 or below 30. Now, this is very, very specific for iron deficiency, but it is probably too low. And even Fletcher then say that if in the presence of inflammation, one should consider even 150 micrograms per liter as the cutoff. Serum, as we mentioned previously, serum iron studies are only used to calculate the transferrin saturation. Just a minute. And then a transferrin saturation of less than 16. But I also think this is very specific, but a pretty, but not sensitive and too low. Okay. Then we look at the soluble transferrin receptor. So when red cells need iron with iron deficiency, the number of receptors on their surfaces increases, and then this spills over into the circulation. It's not so useful in iron deficiency, but the thing is that it is not affected by inflammation. It does, however, increase with hemolysis or erythropoietin treatment. So Fletcher them don't really recommend it at this stage. So I did a sort of a very primitive survey by just phoning the 3 largest pathology practices in the country. They all do a soluble transferrin saturation, transferrin receptor concentrations, but they usually refer to a central lab. Practice A said their reference ranges are 0.8 to 2.3. Practice B, 1.9 to 4.4. And then practice C actually differentiated and gave a higher reference range for males, slightly lower for females, and then a lower one for children. So the thing is, one has to, it seems from this, in any case, that one really has to make certain, ask the lab from which you request the test what their reference values are, and stick to one probably at this stage. So then we get to zinc protoporphyrin. So iron is incorporated into hemoglobin almost at the last step of hemoglobin synthesis. If iron is not available, zinc is incorporated. So one can measure this, but it's a difficult procedure and there's some interferences. So it's probably not, it's not recommended at this stage. Okay, hepsidin. More and more studies are actually measuring hepsidin. The levels drop with iron deficiency. So that the thing is that actually to be accurate and diagnostic, the assays have to measure hepsidin levels of very, very low levels, almost at the lower limit of detection. So at this stage, serum hepsidin is not recommended for the diagnosis of iron deficiency. Okay. Then we look at the American recommendation, Coetzee. The thing is here, they use a study from early 90s that shows that the cutoff level for ferritin actually should be 45. And I think they're talking a lot of sense here. But of course, you know, you also have to do the saturation, the transferrin saturation C-reactive protein, and that sort of thing. Okay, this is the study on which they base it, and just to a lot of ways of perhaps measuring iron deficiency, but you can see that ferritin responds very quickly as iron deficiency sets in. Okay, the WHO guidelines of 2020, these were extremely conservative, and here you can see that they use almost about 15 micrograms per liter. With infection or inflammation, they raise it a bit, and then with apparent inflammation more. But this is if you have a ferritin under about 12 or 15, you almost have no iron left in your body. Okay, this is a systematic review from the Cochrane Database, and Garcia Casal recommended 30 micrograms with a good sensitivity and of course good specificity. But you know, there weren't that many studies, and they mentioned that there were few studies from the global south and people with chronic infections. The British Society suggested the hemoglobin level, but then a transferrin again of 30. But they actually make the common sense recommendation that one should see what the response to iron therapy is if you're really stuck. The Pavord et al. BJH of 2020 talks about the anemia in pregnancy, and they have various levels in various stages of pregnancy, but they're pretty conservative. Again, they use less than 30, that's micrograms per liter, and they don't they don't say we shouldn't rely on the other biomarkers much at this stage. Okay, and I want to thank Vernon for alerting me to this publication by Gelati et al., which includes the people who actually alerted us to the fact that we should use alternative day oral iron treatment because oral iron actually shuts off iron absorption. In any case, they had done lots of stable radioisotope studies on healthy women, just over 1,000, and they had various ages and a fairly wide range of ferritin, values. And they said found that at a level of about less than 50, this is actually, in any case, they call it milligrams per liter, and a corresponding value of hepcidin less than 3 nanomolars, one has iron deficiency. And they base their reasoning on graphs like these. So here we have hepcidin concentration against ferritin. And as we see here, the ferritin, when the ferritin increases, the hepcidin also increases to turn down iron absorption. But here, if they look at ferritin versus the amount of iron from a standard iron meal that volunteers absorb, you can see that when the ferritin drops below 50 micrograms per liter, the absorption increases dramatically, which shows that the person is actually iron deficient. There was also a Delphi round-table discussion about ferritin values published by Navid et al. In the International Journal of Lab Hematology. So they say that less than 30 micrograms in adult patients warrants iron replacement, but then they also to resolve a diagnostic issue. So I think to all intents and purposes, we should stick to a ferritin of 50 micrograms per liter when we want to diagnose iron deficiency. There's another way of determining iron, and that's called the total body iron index. And I'm just mentioning it because it's being used by the nutritional surveys in the United States. So they use a formula in which they use ferritin and then soluble transferrin receptor concentrations. But there's some doubt about the basic science in the background, and it needs to be adjusted for inflammation. But I don't think we actually use it at all at this stage. Okay. So in summary, I think ferritin below 50 in most circumstances, in the presence of inflammation, we go up easily to 100. And now we're just going to look at some interesting situations which might present themselves in your practice. So we're first looking at athletes. So iron deficiency reduces physical performance. Blood is lost during exercise. There's hemolysis, mechanical hematuria, sweating, and then GI loss. For instance, in marathon athletes. And one also gets inflammation from endurance exercise. And the interesting thing is that up to about 30% of female athletes have iron deficiency, compared to 10% in males. It's interesting also that during the ovulatory cycle, the iron indices that we use vary a little bit, but I don't think to such a level that it actually interferes with diagnosis. And then obesity. Obesity is associated with inflammation. And already in 2004, the study in America showed that overweight children have a 2 times greater risk of iron deficiency compared to the normal weight companions. Again, from the Swiss a group of Stoffel et al., central obesity is associated with increased serum hepsidin. So the thing is, it's probably related to the background inflammation associated with obesity. And then another more interesting thing is that overweight pregnant mothers have a reduced iron absorption and also transfer to their fetuses when compared to women of average weight. This is a very decent study, also by that group. Then we just move to cardiac failure. We have anemia from inflammation, dilution, drugs, renal malfunction, malabsorption, etc. The prevalence is around 20 to 30%. And because of the background, also a bit of inflammation, perhaps use a cutoff level of about 100 for ferritin. Iron is mostly beneficial in cardiac failure associated with iron deficiency and anemia. But there is a recent study from Miles et al. From Australia to say that if you replenish iron deficient but not anemic patients before elective cardiothoracic surgery, you don't really win anything. But I still think that one should treat iron deficiency, because I mean, why do you have a myoglobin, etc., and you know, in your heart? So then just a quick look at inflammatory conditions associated with iron deficiency. So then we've talked about heart failure, chronic renal failure, and then of course with the dialysis, patients lose about 2 grams of iron per year. And here's a consensus statement which recommends that one should use a ferritin of under 100 and then a transferrin saturation of under 20%. This is also from the group of Stoffel and Moretti from Switzerland, but they looked at 26 patients with pulmonary TB in Tanzania and followed up all their iron parameters. And this just this thing from the editorial, this infographic just summarizes it. So when we look at active TB and then treated TB. So with active treatment, we have interleukin-6 and lots of hepsidin, which cuts down absorption and keeps the iron in the stores, and erythroferrone secretion from the bone marrow is also then cut down. But they noticed then over the 26 weeks of treatment that the interleukin-6 levels dropped, as did the hepsidin. So and also as the inflammation decreased, the erythroferrone concentrations increased, and so the anemia actually resolved. So I'm just going to look at one or two little studies from South Africa. So Haupt and Weyers looked at functional iron deficiency in hemodialysis patients. They looked at the mean cell volume and then this percent hypo as the percentage of hypochromic reticulocytes, and they found that using the percentage hypo as a single analyte, it actually correlated fairly well with functional iron deficiency in hemodialysis patients. Okay, this is a study from Cape Town which looked at anemia in patients with HIV-associated TB, and their conclusion was that actually in this situation, most of the anemia is attributed to anemia of inflammation more than an iron deficiency. And then a recent study from Wits looked at iron deficiency in HIV-infected individuals, and they looked at soluble transferrin receptors and also bone marrow stores. It was a retrospective study where they looked at the transferrin receptors, iron, etc., and then actually concentrated on patients who have had a bone marrow. So they enrolled 60 patients, almost 20% had iron deficiency, 80% had anemia of chronic diseases, and there was a sensitivity of about 60 to 50% when they used the index from looking at soluble transferrin receptors and ferritin. But this is a small study. We can, but let's look at what happens. Okay, my concluding remark is that it's worthwhile treating iron deficiency, and I think we should just be sensible at this stage. There's no single test that can really stand on its own, and so we need to look at a bundle of tests and eventually make a clinical diagnosis combined with the lab reports. Thank you very much.
Thank you so much, Marius, for a superb overview and very, very comprehensive. I must say, it's been a long time since I've heard such an extensive talk covering so many of the elements connecting both pathophysiology and diagnostics. So that is really great. Can I ask the audience, are there any questions or comments from anyone? You can also put that in the chat if you want to. Marius, I will start and maybe ask just a question about the, what do you think is the reason that labs would be reluctant to change their reference ranges for serum ferritin? Which is a very real problem, as you know.
Yes. Look, for determining reference ranges, usually one looks at a few hundred people that are supposed to be normal, and then kind of looks at 2 SDs. But if you for instance, if you look at serum triglycerides, it's a very small percentage of the population that actually has raised triglycerides. So the whole you can't really use the standard assume that all analytes have a normal distribution. And I think basically what the labs do is they just take mean and 2 SDs, and that because serum ferritin, you have most people, and the majority of patients are at the lower side of the range, and very few at the top. So I think they will really have to just use non-parametric stats to work out their reference ranges, and I think we'll just have to pressurize them. Yes.
No, that I totally agree with you. And I wonder if I can perhaps quickly share something on my screen.
Please,
I'd just like
please
to share
let
one
me,
slide
yes,
as a follow-on on that thing, because I think this is quite interesting. So this slide was shared with me by Jeannie Callum. Jeannie is one of the leaders in the world on in blood transfusion in Canada, and we had a discussion the other day. And this was how she said what we should actually do to find the correct ferritin value. And I think the problem is that I don't know if anybody has ever done this properly. So you start at the top. Actually, here you can see, start with an unselected patient population, then you exclude anemia, and you exclude in order to find a so-called normal population at the end. The reality is that's a big criticism against the low cutoff values. It's often been used taking so-called normal, healthy people, but in actual fact, a lot of these people are either blood donors. We know from literature, 60 to 70% of blood donors are iron deficient to start with, but they're now supposedly healthy. And then there is young women who have not clinically evaluated for whether they have iron deficiency or not. So there's a lot of problems, and some of these numbers date from the 70s and from very long ago. I really hope that we can get to a place, because it makes it very difficult also when we want to treat these patients. The medical aids don't want to pay, because they say a ferritin of 20 is supposedly normal, which it is obviously not.
No.
Prof. Cassianides, I see you've got your video on. Did you have a question or comment?
No, just enjoying the discussion. What is normal, Vernon?
What is normal? What is normal? That is the question. It's one of the big questions in life as well.
I wonder, Vernon, the other thing is also that at this stage, all the iron studies are done by chemical pathologists.
Yes.
And they have don't have iron deficiency in their focus, actually. Yeah. So I think we'll just have to start sort of pulling in Kempath.
Yeah, you're so right. That's what we're doing now. We've embarked on a research project, and I'm also going to write, we're also writing an article with our local chemical pathologists in Cape Town. And I think it's going to be great to sort of search the literature together and work through this. And we've got wonderful people. We've got people in chemical pathology in UCT that are really interested in this. So I'm excited. I think we're going to do some good things. I see there's something in the chat from Dr. Chongo, who mentions that in some inflammatory conditions, ferritin may actually be in the thousands, even though the patient may be iron deficient. How reliable is it in these states? And I want to support Dr. Chongo. I had a young teenage girl, about 15 years old, I think, just 3 months ago, newly diagnosed with TB. Ferritin was 1,200. And after 6 weeks on TB treatment, ferritin was down to something like 40, which just shows you how significantly the ferritin can rise. And it was pulmonary TB. It was not extensive, it's limited pulmonary TB, but still a very, very dramatic inflammatory response. But what surprised me was how rapidly that ferritin came down.
Yes, yes.
On treatment. So, but do you have any comments on that, Marius? It's a very common issue.
Yes, I think basically, you know, the labs try to make get their tests accurate, sort of in the range that where most people are. And I think when ferritins start going kind of over 150 around there, they lose accuracy completely. Probably, you know, I mean, it just shows there's a lot of inflammation.
Interesting. We had a conversation with someone, just trying to remember who it was, but he was basically saying that in their hospital, patients with COVID, ferritin was a very strong prognostic marker, and that most of their patients with ferritins over 1,000 ended up going to ICU over the previous rounds of COVID. So it's also interesting that it really reflects, I think, often reflects severe inflammation, macrophage activation, often hemophagocytosis. I see Dr. James Karish had his hand up. You're welcome to unmute yourself. And
yes, thanks very much. Thanks for that talk. Marius, you had a throwaway line there, which I found quite intriguing, more at a clinical level, and that is you said that people who are on iron replacement therapy often do better if they take it on alternate days. What I'm alluding to is there must be more for you to tell us about the so-called intestinal barrier concept, because patients who are perpetually on iron these days, people are to put themselves on iron through their pharmacist, actually may derange their iron profile so dramatically that by the time they get to you, you don't know how to interpret it anymore. So could you chaps just say something more about that?
Yes, look, the thing is that when you're taking any supplementary iron, the system recognizes this as an excess and then shuts off absorption, so that you then don't absorb actually any iron for the next 48 hours. In the meantime, the iron is irritating the gut lining. It's killing off your gut bacteria, and the patients end up with sort of logarithmic constipation. And this Moretti and the Stoffel et al. Showed that this is the best thing is to alternatively they dosing, or even just 3 tablets a week. But the thing is, if people have been drinking a lot of iron, their serum iron will be very high, and that will influence that will push up their iron saturation, which will make your tests difficult. Vernon?
Yeah, no, thank you, Marius. So that's I can just concur, but there's maybe 1 or 2 other comments. The one is something people don't often appreciate is that you have to do transferrin saturation fasting. I've seen, I mean, it's well published, but not often known. I had a patient with, it was actually a medical doctor, a GP, who came to me and said she doesn't understand the iron results. Transferrin saturation was 80%, 80, and ferritin was like 30. And I asked if she did fasting. She did not. Said, okay, let's repeat it fasting. And after which if transferrin saturation was less than 20%. The second aspect around the oral iron and hepcidin rise, so that's in particular a problem with the ferrous ions, the 2+ ions that contain the extra electrons. It seems like there's been some data on iron polymaltose where they could not show any rise in hepcidin. I looked at an article this afternoon. Let me quickly open my screen again. I've actually had it on my computer. So I was like, this is a late last year role of oral iron treatment of adults with iron deficiency. Just want to show you this. So as Marius said, when you take ferrous sulfate, they're referring to that here, your hepcidin goes up. And so clinical trials of oral iron in younger women have shown that the hepcidin synthesis is stimulated within hours of oral iron supplementation. And this is a key driver limiting the efficacy, as evidenced by the fact that the iron bioavailability is diminished by 35 to 45% on the second day after oral iron supplementation. And then here you can see the interesting data. If you take a dose of 60 milligrams of elemental iron, the absolute absorption of that is 13 milligrams if you did not take iron the day before. If you did take the iron the day before with that rise in hepcidin, that absorption drops to 8.8. And if you go to twice a day dosing, your absorption goes to 5.9. So we've completely stopped any twice or three times a day dosing. We only do for ferrous sulfate. I also do like Marius. I do the Monday, Wednesday, Friday, 3 times a week. And if you have a patient where you're worried that they might forget or not, not be as adherent with it 3 times a week, then maximum once a day. So yeah, no, but thank you for that very, very important question. Dr. Garish, maybe one last question from you, but then I see it's 17:32, then we'll have to close. Yes. If you can just unmute yourself.
I was just saying thank you for answering the question. Thank you very much.
It's a pleasure. It's a pleasure. Fantastic. Okay, so this was a great session. Lots of interesting discussion. Thank you for the comments and the questions also from the audience. We really appreciate it. Special thank you, Marius, for your talk and the clearly massive amount of reading that you must have done to distill these pearls of wisdom out for us. Thank you for that. Really, really enjoyed it thoroughly. I am biased, of course, because I just love iron, but anyway, still I love this too. Thank you to the Echo University New Mexico team and the Echo India team that was providing technical support for us today. The recordings of these sessions will be available on the Gastro Foundation website. And I really want to encourage everyone to share that information with your teams, or maybe watch this video in one of your journal clubs. We really, really want to create awareness around iron and iron diagnosis in South Africa and Sub-Saharan Africa. Thank you to the Gastro Foundation. Thank you to Professor Chris Castianides, who's such a fantastic motivator and supporter of everything we do in patient blood management. Chris, we can't say thank you enough to you. Thank you, Cheryl Valentine, for all your, and Karen Fenton for all the things you do behind the screens for us. Thank you to our sponsors. And then just to remind everyone that next week will be inflammatory bowel disease for all our gastroenterology colleagues and internal medicine colleagues. And we wish you with that a wonderful evening and a great week. Thank you so much. And thank you, Marius.
Thank you, Marius. Thank you, Vernon. Thank you.